You're listening to GLC on ReachMD. This activity titled Talking Through Treatment, Patient-Clinician Dialogue on Perioperative Immunotherapy in Locally Advanced Head and Neck Squamous Cell Carcinoma is provided by Global Learning Collaborative. Prior to beginning the activity, please be sure to review the faculty and commercial support disclosure statements, as well as the learning objectives.
This is CE on ReachMD, and I'm Dr. Adam Luginbuhl.
I'm Dr. Jennifer Johnson.
So Jen, today we are going to be talking about the new paper that came out, Keynote 689, and neoadjuvant and adjuvant immunotherapy for head and neck cancer. Let's first start by telling us and talking about how we determine a patient is eligible for perioperative immunotherapy.
To be fair, that is a very collaborative question. And there's going to be some pieces of that I'm going to answer, some pieces that you're going to answer, and some that we can both take some responsibility for. Because the key components are, what is their biomarker? So for this, it's that PD-L1 CPS score needing to be 1% or above. And frankly, that is the minority of patients who aren't going to qualify based upon that. We're going to be looking at their comorbidities. Do they already have an autoimmune condition? Do they have a solid organ transplant? Is there something about that patient that puts them at risk for immune-related adverse events where we wouldn't want to necessarily challenge them with neoadjuvant immunotherapy or even necessarily the adjuvant components, which you can consider separately? You're going to ask whether or not that patient is resectable and whether resection would be a natural part of the way that we treat them for their head and neck cancer. Adam, can you give our audience any tips for how you select patients for this, and then building a practical workflow for making that happen in the clinic?
I really think that started with simply recognizing that the time between when I saw the patient to the time when you see the patient is really the spark point. If we delayed that, everything seemed to unravel. If we were in lockstep together and we were seeing them either the same day or within the same week, I felt like as a surgeon, I was comfortable with that handoff and co-management of that patient. So a lot of challenges there that we had to work out and encourage our listeners to really kind of walk into that together with their colleagues. Jen, now that we have someone that we've identified and we want to bring them in, how do you manage and think about and monitor for potential immune-related adverse events for someone on perioperative immunotherapy?
We're looking at some baseline labs. I am looking at labs when they come in for that second cycle, so that is 3 weeks after the first dose of immunotherapy that they got. And then I'm looking again about 3 weeks later before they're going to the operating room. So I am looking a couple of different times to see if there's any laboratory studies that are pointing me in one direction regarding any immune-related adverse events. And I'm also talking to the patient at each of those points. So the immune-related adverse events, we're thinking about thyroiditis, we're talking pneumonitis, we're talking colitis, we're talking dermatitis, and we're trying to think about how we're going to manage them specifically with operative safety. Now, we're sort of used to this at this point as medical oncologists. And if you look at the immune-related adverse events that happen on the trial and that happen in the perioperative period, they're exactly what you expect for single-agent immunotherapy. We didn't get any surprises here. Adam, how do we measure success for our perioperative immunotherapy?
So to the question about success, the trial was set up to activate our immune system. It was not set up as a classic chemotherapy, tumor reduction, cytoreduction type protocol. It was the science behind this is really embedded in the idea that the immune system has something wonderful that it can offer our treatment of our cancers. And so when we think about it, we're really looking at the numbers of patients that have success 2, 3, 4, 5 years down the road when they don't have that recurrence that we would normally see. And so we consider event-free survival. So if I have a patient and they come in and they get on immunotherapy and in 2 days I take them to the operating room and I don't see a pathologic response, I don't consider that a failure because I'm not expecting that. When it does happen, which it does, we do have a percentage of patients that do have a response. That's wonderful, but it doesn't mean a no response on the pathologic side is a failure of the immune activation. So we really are truly looking at that immune profile shift, which may be invisible to us until those 10, 15, 20 patients in a population 3 years down the road don't get a metastatic lesion or don't recur. This has been an amazing time together. Our time is now up. We hope that this overview has been helpful for your practice, and thanks again for listening.
You've been listening to GLC on ReachMD. This activity is provided by Global Learning Collaborative. To receive your free CE credit or to download this activity, go to reachmd.com/CME. Thank you for listening.